Hi, I'm Meta Spencer. Today we're going to have a very, very important conversation with two epidemiologists who are longtime friends, who've known each other and worked together in very important contexts. I'll start with my local friend, whom I already know, Dr. Ronald St. John, who was a member of the Public Health Agency of Ontario. He was on the Strategic Planning Committee, and he was the Director General of the Center for Emergency Preparedness. This all happened when the SARS epidemic took place, so he was the man in charge of SARS in Canada. And then he became the Ebola incident manager for the Pan American branch of the World Health Organization. That's North and South America. So, and he knows Portuguese and goes to Brazil and does things there sometimes too. So, and most recently, since he's retired theoretically, he actually is the chair or the founder of something called CITADA, which is an organization that actually provides information to people traveling around the world in case they need to know what kinds of bugs they might run into and where to get a good doctor if they do. So he is, this CITADA outfit is apparently very much in demand lately anyway with airlines. Good morning, Ron St. John.
Good morning, Meadow. Thank you very much.
Good to see you here. And in London, at least I believe you're in London, England, are you not?
Yes.
Is Dr. David Heyman, the London School of Tropical Medicine or something, is that right?
That's right, madam.
Okay, I don't know where my little crib notes are, but you're going to have to tell us because I know you're an important man, very important.
Well, not so important. But I was with the Center for Disease Control out of Atlanta for my career, and that career started with smallpox eradication in India, then 13 years in sub-Saharan Africa, beginning with the first Ebola outbreak. I stayed on after that for 13 years. And then I was at WHO in various roles and positions. And Ron and I worked closely together during the SARS outbreak in 2003. But we've known each other for many, many more years, including when Ron set up a new innovation in Canada back in the late 1990s called GPHIN, Global Public Health Intelligence Network, which became a major source of information for WHO on rumors about what was going on in infectious disease around the world that could then easily be investigated. And it saved many, many lives because of this application sitting up in Canada, providing input to the World Health Organization.
I want us to talk a little bit about that before we get going, because that's actually how I met Ron. I happened to be watching a video of, I think, Larry Brilliant, and he was waving at Ron, who's in the room, and talking about GPHIN. So I thought next time I wanted somebody to be on my, it was when I was putting together a conference. I did a little detective work and tracked down Ron St. John, who turns out to live not too easier in Canada. So anyway, so it turns out what this GPHIN thing was a big time, excellent project, which there's a scandal, that the Canadian government messed it up. And I don't know which of you would like to bring us up to date on what that was and why it was so important and why it was such a terrible loss that the Canadian government killed the project.
Well, Ron, maybe I'll start by saying how we got this involved with WHO.
Yes.
Because an emerging infections meeting in Atlanta back in the late 1990s, Ron and I discussed this, and he said he had this wonderful application which could search the web looking for keywords that indicated outbreaks of infectious disease. And so we immediately saw the link that this might be very important for a new intervention at WHO called the Global Outbreak Alert and Response Network. And so this GPHIN actually collected information every day, provided it overnight to WHO, and in the morning, WHO went out to its regional and country offices to verify whether or not these incidents were occurring, and if they were, then responded. So over to you, Ron, to take it from there.
Thank you, Dave. I'll start with an anecdote, if you don't mind. because it's what generated GFID. Sitting in my office in the late 90s and watching CNN News, I had a small TV set and would watch CNN. And there was a picture, live picture of people fleeing the city of Surat in India because of the possible outbreak of pneumonic plague. The worst kind of plague you can have is plague in your lungs. And they were fleeing and pushing carts and bicycles and cars and everything. I thought, oh my, that's really a bad scene. Anyway, that's far away from Ottawa, Canada. Except that 1 hour later, I got a call from the director or the CEO of our biggest and busiest airport, Toronto Pearson Airport. And he said, there's an Air India flight that is coming from India, and it's past the turnaround point, means it can't go back. It has to land in Toronto. And everybody in the airport, all 30,000 people, were going to go home because they were afraid there was plague on that airplane. So all of a sudden, a faraway problem was sitting in my lap because he said, do something. And we did. Well, to make a long story short, I was able to send one of my quarantine officers to get to Pearson Airport before the Air India flight, because it's only an hour flight from Ottawa to Toronto. He got there, had meetings with people real quick before the Air India flight landed, calmed everybody down. The flight pulled up to the gateway, but didn't touch the gateway until my quarantine officer went out and he opened the bay doors, looked around and said, there are no fleas and no plague on this airplane, and everybody was happy. But it caught us flat-footed. And we thought there must be a way to get information so we can be better prepared, initially to protect Canada and Canadians. And we thought the internet, a brand new thing, this internet, and maybe we could search the internet and find media sources, because newspaper writers like to write about diseases. And so to make a long story short, it worked. We were able to scan newspapers worldwide, and then we began to realize we could provide alerts for the world, not just for Canada. And we entered into agreements with CDC in Atlanta, with WHO, with others. And GFIN was great until 2019, where unfortunately, because of changes in management and management style and management priorities, GFIN was told not to issue any more global alerts. This was in May of 2019. What's that, about 7 months before COVID-19 hit. That was a bad time to stop issuing global alerts. And there was a panel of inquiry. There have been recommendations for changes. So GFIN is in a process right now of change, maybe expansion. Not sure exactly what directions it's going in. But anyway, that's the story of GFIN.
Meta, let me tell you how powerful GFIN is, because it's really an incredible tool. Sitting in Geneva, we received one morning a report of an outbreak of a respiratory illness with high mortality in Afghanistan. And this had been picked up in Tajikistan in an English-speaking site in the capital city and was transferred to Geneva. And then Geneva went out with a team, did an investigation, and that investigation showed that this was really only seasonal influenza in a population that had not had influenza for quite a while, but it could have been something much worse. But from Tajikistan back to Canada, to Geneva, and then a team going out within a period of 2 days to Afghanistan was really a remarkable demonstration of the power of this system. And this system also was one of the initial ones to pick up what was going on in China in 2002, November of 2002, when the Sars outbreak was beginning in China, and China was trying to hide it from the rest of the world. So it's a very powerful system.
And it was killed completely by the time COVID began. Is that what I'm to infer?
No, not exactly killed, Meta. It was instructed not to issue global alerts. That didn't mean that it wasn't.
Well, that's the main thing it's good for, isn't it?
Well, it was still collecting information, and it was sharing that information with Canadian government sources and so forth. But there was, I think, in my opinion, unfounded concern that Canada could be held liable in some way for mentioning a problem in another country. That never happened. That never happened in the 20-year history of GFIN. But there was concern. Anyway, I think it's in transition now. It's not dead. It's not finished, but it's in transition, and hopefully we're thinking about ways to bring back its original mission. So I'd just say stay tuned.
Well, is there any way any other outfit could or has already begun doing what you were doing? Did you have a unique role to play that nobody else has filled or not?
No, there have been other institutions that sort of jumped into this idea of monitoring the world for outbreaks of infectious disease. There's a thing called Health Map at Harvard University. There's ProMed. There are others that do the same monitoring. Outbreak News. So it was the first of a generation of systems looking at international outbreaks of disease, and it goes on. I think there will be some kind of transition, and I don't think GFIN is dead.
Mm-hmm. Or you use any of the same things in Citata? By the way, let me tell you people, the viewers, it's SITATA.
Yes,
and it's
right.
a company, so that if you're a traveler, maybe you want to get into their network, whatever they do. You want to talk a little about that, Ron?
Well, it's the same basic principle, but in this case, instead of providing advice to governments or international organizations, if a traveler registers their trip with us, then we monitor where that traveler is going. Mm-hmm. If there's any kind of a problem for the traveler, outbreak of disease or a bomb goes off in the marketplace, we have an app and they get an instant alert 24/7 with advice. So it's more focused on the individual rather than the government. But it scans tens of thousands of newspapers every 5 minutes.
Wow.
The computer, just to give you an idea, when we started GFIN back in the late 90s, and we were looking for a search engine to go to check the internet, the fastest search engine would take one whole month to make one pass of the internet. Mm-hmm. We wanted to pass every 5 minutes. Nowadays, you click Google and you get 3 million answers in half a second. So the world has changed completely from what it once was.
Well, you can't use 3 million in half a second. Then what do you do?
No, you can't. But anyway, listen, I'd like to get back to David and his expertise and his worldwide experience, and I'd like to chat a little bit, if we could, about where we are in COVID from the world's perspective, and now that we have 2 years of COVID under our belts, and we've had vaccines and we have therapeutics and whatnot, I'd like to ask David what he thinks. What's going on in the world now with COVID, because it certainly hasn't disappeared.
Well, yeah, thanks, Ron. And maybe I'll preface that with a study that was done in 2004. In that study, a group of molecular biologists took all the known specimens of human coronavirus OC43. This is a virus that causes the common cold, and it causes slight immunity, but you can get reinfected. So they took this virus and they took all known specimens from 1950s onwards, and they did a genetic sequence of those specimens. And then they roughly calculated a rate of mutation from 1950s onward up to 2003. This virus is thought to have come from bovine species, from cattle. And so they did the same thing with cattle. And when they went backwards with both the cattle and the human mutation rates, they crossed the axis at a point between 1850 and 1890 by three different methods. At that period, in 1888, there was a pandemic called the Russian flu, which had over 1 million deaths reported in a very small world at that time. But more importantly, there were neurological signs and symptoms which don't occur with influenza. Though there are no specimens available, their hypothesis was that this was the emergence of human coronavirus OC43, caused a pandemic, became endemic, and is now held at bay by population immunity. I think it's a hypothesis, but it's a good model with which to look at the current.
Excuse me, I want to
yeah,
check. Now, this number you gave, this coronavirus, are you suggesting that it's similar to or the same as our current COVID?
No, it's one of 4 endemic human coronaviruses that are in people at all times and that cause the common cold. But it's a relative of the current coronavirus. But what it shows is that these coronaviruses, at least 4 times in the past, have emerged and established residence in humans. We have 4 endemic human coronaviruses. And Ron, to answer your question, I believe that we now have the 5th endemic human coronavirus, SARS coronavirus 2. What's been interesting to me is to see the UK strategy, which in my view has been the right strategy from last August. Because in last August, they began to shift the risk assessment that was done by the government, which is what ended up in lockdowns, to people. So that people did their own risk assessment. The government provided free test kits to anybody who wanted them. And you could test yourself before you went to visit relatives or family or whatever. And you could then take your own measures to make sure that you didn't transmit that to people, doing your own risk assessment, your own risk management. At the same time, they ensured that vaccinations were given, and there's a lot of trust here in the UK in the national health system. And so vaccination rates are very high in the UK, and they've offered boosters to those people, elderly and with comorbidities. And at the same time, natural infection has also occurred in people who weren't vaccinated or who have been vaccinated, because you can be infected after vaccination. And they now have a population immunity. They have over 99% of the population through random surveys that have been shown to have antibody to SARS coronavirus 2. They've shifted their surveillance not to the number of infections occurring, but to hospitals. Can their hospitals cope with the disease that's occurring? And is that disease moderate? Does it cause demands on the intensive care units? And is it causing mortality? And they believe now that they're at a plateau where this virus is endemic and being held at bay by population immunity. And they will be giving some precautionary boosters to the elderly, to those people in our age group, Ron, in the autumn. That will be the 5th time that people have been vaccinated against the coronavirus in the United Kingdom.
I've been very interested in some people who have said that one of our major achievements has been to uncouple the infection incidence from the hospitalization and deaths, meaning that now we can have a large number of people infected, but it won't collapse our hospital system. There'll be a limited number of people entering the hospital system. Still, if you have a large number of people infected and a small percentage of them are going to go in the hospital, as some do, a small percentage of a large number could still be a large number, David. Is there still concern that our hospital system, although not responding as before, could still be stressed with expanded infection by, say, the new variant BA5?
Yes, and you know, that's what happens in every flu season as well. When seasonal flu occurs, hospitals are stretched. And so, yes, there's a big risk. And that's why there's a strengthened influenza-like illness surveillance system that does genetic sequencing on virus, just like it does for flu, does also on SARS coronavirus 2. And the government is giving these boosters as a precautionary measure, hoping to keep the disease at bay. Vaccines so far have not been shown to be ineffective in preventing serious illness and death, but they are ineffective, as you know, in preventing infection after vaccination.
One of the things that I haven't seen talked about too much is exactly the implications the implications of what you just said, that it doesn't stop us from becoming infected. And I had to smile when Dr. Fauci said we could be infected every month. Not quite, but if we are infected repeatedly, but not ending up in the hospital, we could still have, in a relatively short period of time of a wave, we could have a large number of people out of work at home because they are sick with various degrees of illness. So we would have a shortage of nurses because they're sick at home. We could have a shortage of grocery clerks, a shortage of restaurant waiters and waitresses. And anyway, I don't hear people talking about that. Do you feel that there is this hidden risk with the expansion of infection?
Well, in the influenza season, that's exactly what happens. That's why Canada went to a universal influenza vaccination program, at least in Ontario. And you know that better than I do, but as my understanding, that it has decreased absenteeism in schools, at the workplace, and that's hopefully what will happen now with the SARS coronavirus 2 as well. So, I think we have to get this myth out of our mind that this is anything special. This is an emerging infection. It's now endemic, and we need to deal with it. And we need to deal with it as we do with other respiratory infections. With the endemic coronaviruses, we know you can be reinfected every 6 months with a common cold. And hopefully that's what will happen with this as the population becomes more and more immune. And hopefully the mutations and the variants will slow down as well. We don't know what will happen, Ron, but we have to get on with life and have the right systems in place to tell us, you need to be careful now, get some more booster doses of vaccine out because hospitals are seeing an increase in cases. We're just so lucky.
I wonder, you say 99% of the British population show the antibodies. Okay, now what does that really mean when you've said that every 6 months these guys can get sick all over again? Is that what we have to expect, or can we expect to build up immunity so that the odds are more in our favor? I can't imagine the statistics involved in this. What do you predict?
Well, what I predict, and Ron, you can say what you predict, but what I predict is that this is a coronavirus, like other coronaviruses. Population immunity will keep it less serious and keep people from dying, except those, unfortunately, who are elderly or have comorbidities, who may be at greater risk of serious illness. They are at greater risk of illness from influenza, from serious illness from influenza. So we're going to have to live with this. We understand that coronaviruses that exist in the four that do exist are causing the common cold, and hopefully that will be the outcome of this over time as population immunity continues to be stimulated by infection. In sub-Saharan Africa, they haven't vaccinated very many people. They haven't really noticed in many places increased morbidity or mortality, increased disease or increased death or increased hospitalizations, yet they also have immunity in their populations that sometimes exceeds 90% in communities or in urban areas, which suggests that this virus has been less serious infecting younger people in Africa, because the median age in Africa is 18 years. So maybe Africa has survived because of less serious infection. A hypothesis only. But Ron, I'm going to turn it back to you because you have some different views, I believe.
Well, I I feel no. I think I agree that it's something that's going to recur. People overlook, or not overlook, but don't appreciate, I think, the fact that every year in Canada, at least between 3,000 and 4,000 people die from influenza every single year. And yes, we promote influenza vaccine to minimize the number of people who get sick, but it doesn't stop influenza totally. It makes it more manageable. And I think the fact that we have succeeded in creating immunity, I think it's mostly the cellular immunity that keeps us out of the hospital. The antibody IgG immunity is not that good. As you know, it doesn't stop infection that well. But we do have our cellular immunity as our background, and it keeps us out of the hospital. And as long as we can keep that up, as long as we don't run into a mutation that overcomes all of that, then we're going to, I think, do all right. I think that what we're going to face around the world is there will be some countries where, because the vaccination wanes or because of different factors, we will see waves. There could be a wave in India, but not in the United States, not a global wave. We will see a wave in some other country here and there. And one of my concerns is about equity, which has gotten a lot of attention for the distribution of vaccines, especially in countries that have difficulty with systems for distribution of vaccines and expensive therapeutic medications. So I think it's going to be endemic. In some countries, it'll be smoldering, low levels. In some countries, we'll have periodic waves that'll come and go. So, I mean, that's how I see it evolving.
Okay, but now you're talking about the same disease with little variants. I don't understand the difference between the variants and a whole new event, because, you know, when you talk about a worldwide wave, it could be a new coronavirus. Is that what we want to say? Or it could be just a variant of what we've already had. What do you expect there? I don't quite know what people are expecting to have happen.
Well, I would expect the virus to mutate. It has been, and it will continue to mutate. But it seems to be mutating mostly in the area that helps it attach to the cells. It doesn't seem to be mutating in the main body of the virus that may or may not be responsible for how sick it makes you. The thing we don't want to see is a mutation that makes it that increases its mortality. And right now, the variations that keep coming along, each one is more infectious than the other, but not necessarily more viral in terms of mortality. That's the good news. But that'll probably keep going on.
When David talks about 5 different coronaviruses, are these like each one is a mutation from the previous one, or what? How does this happen? Are they all mutations from each other?
No, Meta, these 4 endemic coronaviruses are 4 different viruses. They probably emerged at different times. One is thought to have come from a camel, from possibly a bat into a camel. One is thought to have come from cattle, which is the OC43 that I talked about earlier. There are 4 different viruses. And now we have a 5th, which is the SARS coronavirus 2. And what Ron says is right. We don't know what will happen. This could come a wave in India and cause nothing in North America. We just don't know what this virus will be doing, but we know it's unstable right now and it continues to mutate. And that's the way the influenza virus does as well. It mutates so that each year you need a new influenza vaccine, which is based on the mutations that occurred in the previous year. And so, but if there's good news about the coronavirus outbreak, and I'm sure Ron will agree with me, it's the way that vaccines were developed so rapidly and new platforms of vaccines, which will be much more easy to adapt in the future if there's another new virus that enters human population. And the developers of these vaccines say that they can also develop vaccines for bacteria. And that could be a solution to antimicrobial resistance because you prevent bacterial infections and you don't have to use antibiotics. Already, no doctor in North America treats pertussis whooping cough anymore with antibiotics because vaccines have prevented it. And hopefully we can deal with antimicrobial resistance through these new vaccine platforms as well. But what Ron says, and I'd go back to him, is the problem of equitable distribution of these vaccines to the rest of the world. And that's really important.
Okay, that's the first time I've heard people talk any mention of bacterial vaccines. That's wonderful. I don't, of course, I don't know. But I've also heard people talk about developing some sort of universal vaccine. Presumably, it's one that'll handle any coronavirus that comes along or any variant of the same virus. Is that right?
Well, I think that would be ideal, but I think it's going to be difficult because the mutations create, it's like creating a cousin of a virus.
Mm-hmm.
So if you have a virus A and it mutates, now you have virus B. It's a cousin. It's related, but it might be sufficiently different that you need a slightly different modification to the vaccine. And cousin B creates cousin C, and again, it's unique, but it's related. So, I mean, that's the world of mutation of the virus. It's a constantly changing thing. As we adapt to the virus adapts to us, and it's ongoing. Mm-hmm. So, I mean, I think that's going to happen with the coronavirus. But some viruses mutate much faster than others. Some don't mutate hardly at all.
Mm.
And you know, Ron, I think what you're saying is absolutely right. And as you know, there's work on a universal influenza vaccine as well. It would be the vaccine which prevents all future mutations or anything that occurs with the influenza vaccine. I think we're just on the threshold of some really wonderful advances coming forward in vaccines. I think it's really incredible.
I agree.
Would you talk a little more?
Matter, if I may, just one of the challenges is we're trying to predict the future. Trying to predict what would the virus look like if it's cousin X. You know, what will it look like? So we can make a vaccine that will make antibodies against not only cousin A, B, C, D, E, and X, but X is in the future. It's a challenge. It doesn't mean there aren't progress. There isn't progress made towards that, but I see it as a big challenge.
Mm-hmm. Okay. Now, you mentioned this thing about bacterial vaccines, that this will take care of the antibiotic resistance. That sounds like a big news to me because I hadn't heard that. Can you talk a little bit more about that possibility and how far that is from present?
Well, we already have vaccines that prevent bacterial infections, Haemophilus influenzae, a whole series of bacterial infections that can be prevented with vaccines. So the secret with those is to get the coverage up so that these infections decrease, and therefore you can decrease as well the use of antibiotics. So that's one possibility. The other is to develop vaccines for diseases which have had no vaccines. Take a good example, gonorrhea or syphilis, which are two infectious diseases which require antibiotic treatment. If you can develop vaccines that prevent these infections, you can prevent the use of antibiotics. So it's not the solution, but it's one solution, and there should be equal attention paid to this as to the development of new antibiotics. And unfortunately, that's not occurring in the world. There's more emphasis on new antibiotics at present than there is on bacterial vaccines. And hopefully we can get both of them to be well-funded moving ahead.
Mm-hmm.
You know, it's interesting to me that, tuberculosis is still a major killer worldwide. And for years, people have been trying to find a vaccine against tuberculosis. There is a BCG vaccine, but it's limited in what it can do. And I would contrast the investment in a search for a vaccine for tuberculosis with the investment that went into the coronavirus vaccine development, which I don't know. I don't know at this point in time how much money the world has spent on the coronavirus vaccine as compared to the amount of money spent on tuberculosis vaccine, which has got to be a little tiny fraction of the COVID amount. So there are different diseases get different priorities depending on a whole constellation of political and social and economic factors. And yeah, this equity thing, trying to balance out one disease against another, the abilities of one country against another. How do we get equity across a broad spectrum of diseases?
Are you saying that you think that there are some diseases that have been inappropriately prioritized, that maybe we paid too much attention to certain diseases and not enough to others? And if so, which ones?
Well, I think that the diseases that affect the rich Western countries are the ones that get priority. There are diseases that are quite significant for smaller groups of populations. I don't mean small groups. I mean other nations, smaller nations that just aren't of interest to the major research investments in the Western world. And so they do not get the attention until the disease shows up in the Western world. I'm fascinated watching the monkeypox situation right now, as the Western world scrambles to respond to demand for vaccine against monkeypox. Well, we've had monkeypox outbreaks in Africa, and nobody was scrambling at that time for vaccine usage. I don't know. What do you think, David?
Yeah, I agree with you entirely. And, in fact, every year I teach in a 2-week vaccine course, which is between the National University of Singapore and the London School of Hygiene and Tropical Medicine. And this year, the course was by Zoom. It was in Ghana, but it had public health leaders from around Africa. And at the end of the course, we asked them what their vaccine priority would be for their country. And of course, they all said malaria. They said, we need malaria vaccine. Then the question was, do you need COVID vaccine? And 3 of the participants responded, that's a tool that the North wants to force on us in order to protect themselves from mutations. So, we have to listen as well to what countries want and what they need. And countries one day may say TB as well. We should be saying TB because it affects all countries. And hopefully these new vaccine platforms will in fact make it possible to develop an effective TB vaccine as well. So we have to hope, and we have to keep it on the agenda.
Well, what's the story with the malaria vaccine?
There is a malaria vaccine, and it's about 50% effective in preventing infection in children, but it's the first generation vaccine. That's quite good for a first generation vaccine. Now there will be more work to develop the vaccine further, or maybe different approaches. And I'm pretty confident that with new platforms like the mRNA platforms and others, there will be a lot of research on malaria. What do you think, Ron?
Yeah, I agree. And, we're getting to a point where we actually have some powerful tools to deal with malaria. If this vaccine holds up in practical use, you now have 50% of the children protected, but you add to that insecticide impregnated bed nets, and you add to that insect repellent in certain situations. You're beginning to put together a constellation of tools that, as we wait for better and better vaccines, those tools can be highly effective if they can be distributed in the population. And sometimes the biggest obstacle is the distribution system in the countries, the healthcare system, especially in remote areas where access to healthcare is often limited and is sometimes kilometers away from where you live. So the distribution system and building the healthcare system is another challenge that that the Western world has got to undertake.
So could you say that what you're looking at is not just, I mean, with malaria, or if it's 50% effective and you use all these other measures like bed nets and things, that you could look toward the eradication of malaria ever, the way I guess smallpox has been eradicated, or not? And by the way, I want to ask about polio, because I think David is an expert on polio, and I hear that the U.S. has one case now, which they never had. How close is the world to being able to eradicate either polio or malaria or any of the other big threats?
Maybe I'll start with polio. Well, first of all, I'll start with malaria. There is no reason that it couldn't be eradicated, because there is no animal reservoir in nature as far as we know. We only know that it occurs from human to human and is transmitted by a mosquito. So theoretically, you should be able to get rid of it eventually, but it's a long attempt, and they attempted it in the 50s, and they got rid of it in a few island countries, but that's all. So, it's a big challenge, but Ronald maybe have a view on that. But on polio, just to come back to polio, there's two types of virus that cause polio. There's the wild polio virus, which is the virus that we've all known and that we've all understood. And there's the vaccine-derived polio virus, which is a virus that comes from the live vaccine, the Sabin vaccine, which mutates. Where we stand with wild virus is type 1 and type 2 and type 3 wild virus polio is gone from the world. It's eradicated. What we have now is type 1, which still remains in Afghanistan and Pakistan, and occasionally it exports. It recently went into Malawi and then into Mozambique, but they stopped it very rapidly. So when Afghanistan and Pakistan get rid of type 1 wild polio virus, wild polio will be eradicated from the world. That leaves us, though, with vaccine-derived polio, which comes from the vaccine that was used to eradicate polio. And that virus is circulating in Africa in many different countries, and it will be a challenge to get rid of it because the vaccine that's being used actually mutates. So there's a new vaccine available. There are all kinds of new innovations that hopefully will stop vaccine-derived polio as well. But Ron, you'll have a view on malaria, I'm sure, and possibly on polio.
Yeah, I was going to say, people don't realize that all through the Mississippi Valley, there was seasonal malaria in the United States. And this is long before bed nets, and this was long before vaccine. It was eradicated from the Mississippi Valley, and actually sometimes as far north as Ottawa. And how was that done? Well, it was a combination of economic factors and environmental factors, and the fact that people began to put screens on their windows and doors. And gradually, the malaria couldn't find people to infect because people were behind screen doors and whatnot. So it was an economic advancement in many ways. Plus, there was also eradication of mosquito breeding sites. So that combination, even before our modern tools, led to the actual eradication of malaria from the United States and Canada. So yes, you can eradicate malaria. It takes a concerted effort, but with the new tools that are coming on board, it's going to be a little bit easier than trying to put screens on every single dwelling in every single country.
I'm thinking back, when I was 8 or 10 years old, 8 maybe, I remember my father got sick, and the word was that he had malaria. Now, we lived in Oklahoma, and I don't know whether how do I know whether he had real malaria or not? But is that a possibility that somebody in Oklahoma who never went into the Mississippi Valley would have had polio in the 30s?
Did you say polio or malaria?
I'm sorry, malaria in the 30s.
I don't know. To be honest, I don't know about Oklahoma.
I think it would be possible, yes. Even today, Ron, as you know, if malaria comes in on an airplane to a country, you know this better than most, it can cause a small outbreak at the airport if the mosquitoes are there. And there's been an outbreak in Miami of malaria called airport malaria. People never traveling, but who got infected because mosquitoes got infected in that area. And as far as I know, that the whole south of the US was malaria at one time, malaria endemic. And that's why the Center for Disease Control, which is in Atlanta, was originally developed. It was the Malaria Control Center. And when malaria was eliminated from the US, it became the Center for Disease Control and Prevention. So yes, malaria, yeah, your father might very well have had malaria.
Yeah, it's possible. They just, I think, what was it, last week or earlier this week? I forget exactly. 2 employees at Frankfurt Airport got malaria.
No.
They hadn't been anywhere. But the mosquito was there, and somebody was able to transfer it to the mosquito. The mosquito then bit the workman, and they developed malaria, we've always called airport malaria. Anyway, do we have enough time? I'd like to, if we could just shift a little bit, I'd like to talk a little bit about the international health regulations, because I don't think a lot of people understand or know that there is such a thing as the international health regulations. Mm-hmm. And we've both been involved in one way or another with them in their revision in 2005, or in their application or lack of application. So I'd like to, and it was very interesting to see the interaction between the international health regulations and the coronavirus pandemic where we've just been in. And anyway, I'd like to get David's impression about how well they worked with what they are, perhaps first, and how well they worked for COVID.
Well, the regulations were actually, as you know, Ron, set up in 1969. And those regulations were an attempt to ensure maximum health security with a minimum interference in travel and trade. And so they were to make recommendations to keep travel safe. And they are targeted at 4 diseases: cholera, plague, yellow fever, and smallpox. Countries reported when they had outbreaks of this disease to WHO. WHO published it, I might say, in quite small print on the back of its weekly bulletin, as you know. And if quarantine officers around the world were reading that, they could then look in the yellow International Health Regulations book and say, aha, there's yellow fever occurring in one country in West Africa. Therefore, people coming from that country should have vaccination, and we can require that at our border. So they were trying to stop infectious diseases at borders. But they didn't work, clearly. Countries didn't report. There's no requirement. There's no way of enforcing it. And if countries reported, they had severe economic loss. So you can maybe pick up the story from them. After SARS 2003, the revision finally was done. And what was that, Ron?
Well, that led to a couple of interesting changes. One was it required that all countries should have a national focal point for reporting events in their country to WHO. And that has actually worked quite well. I think every single member state of WHO now has a national focal point, and they have a linkage, internet linkage, to communicate with each other. And that's good news, because countries now will share information more readily than before. On the other hand, the travel restrictions and travel recommendations is more problematic because countries' nationalistic interests seem to overcome any global interests. So when COVID-19, when SARS virus, coronavirus came along, countries immediately began to issue travel restrictions of various kinds. You couldn't come to my country unless you had a test. You couldn't come to my country unless you went into quarantine. You couldn't do this and you couldn't do that. that's just the entry requirements, not to mention what requirements were placed on the population internally, but that's national business. The entry requirements were quite varied and sometimes quite draconian. At no time, in my opinion, in my knowledge, did WHO ever issue any travel restrictions for coronavirus. So, in a way, the international health regulations were ignored by the member states. And
this is just reinforcing everything I've been thinking about lately, is the lack of enforcement of international law. Now, I would not have known that there was anything that could be called an international law restricting travel. But is that what, would you say that if there had been an issue from WHO that people should not travel or must report cases every time a physician doesn't report a case, if he doesn't report it and it's a new thing, he could go to jail for not doing it. That's the kind of enforcement that we need. But would this kind of directive be considered a binding international law if it comes out of WHO?
Well,
yeah, go ahead, Ron.
The quick answer is no. The international health regulations is more of an agreement. I've heard people describe it as a quasi-treaty because it isn't. It is not. They are not approved by Parliament or by the Congress or by governmental instruments. It's an agreement, and the problem I think we face with the international health regulations is sometimes when push comes to shove, national interest being, I will do whatever I think I need to do to protect my citizens from disease coming into my country. That just trumps everything else.
Yeah.
I don't know what you think, David.
Yeah, I agree. You know, what happened with the regulations is they broadened. They don't just report 4 diseases now. They report what is considered a potential public health emergency or national concern based on a decision tree analysis that countries make before they report to WHO. But countries during this COVID pandemic didn't want WHO to do the risk assessment and make recommendations. They wanted to do their own risk assessment. And they could do that because the information that used to be exclusive within WHO is now everywhere. It's published on the internet in front of the paywalls of medical journals. And so countries can do their own risk assessment and they make their own decisions. So are the international health regulations really a vestige of the past when WHO had exclusive ownership of information because that was where countries reported? Or should they be updated in some way that they permit countries to do their own standard risk assessment? Not clear to me, Ron. I don't know what you think.
Yeah, that is a key question, David. I mean, it's remarkable watching the reaction around the world because, as I said, we were monitoring every single country and the restrictions and how they changed week to week and how the measures they put in place had very epidemiological or scientific basis. It was more political, sometimes fearful. In other words, it just did not have science. And the idea in our modern world, with the way people travel, that you can actually stop disease at the border is probably an anachronism. Especially in a disease where you can have an asymptomatic traveler coming into the country, and there is no test that you can apply to that person to detect whether or not they have disease X, Y, or Z. So the whole concept of the border restrictions, the internet, and in many ways the international health regulations as they currently stand are maybe out of date.
See, what I want is, I don't care who does it, whether it's the country itself or WHO, but what I want to know is that there should be a law saying whenever somebody detects a thing that might turn out to be a big deal, they damn well better report it pronto and let the world know so that they can get onto it. But the business of hiding it for national reasons, the value to maintaining the economy and things like that. The idea of allowing this to be totally discretionary and countries report if they want to, obviously that doesn't work. And I think that's we need international laws, and I don't see why health regulations shouldn't be part of international law. Am I being fanatical or?
No, and that in fact, there are many people who agree with you. And that's why there's a negotiation right now to develop a treaty. Mm-hmm. And as Ron said, treaties are different because they have to pass through Parliament. There need to be national laws in support of those treaties. And the treaty that's being discussed now would be one of sharing freely information, reporting rapidly, a whole series of things that may actually supplement or even replace eventually the international health regulations. Mm-hmm. So a treaty is being negotiated. Ron, what do you think will happen to this treaty? Do you think it will eventually be accepted or not?
That's a good question. I don't know, David. I really don't know. Sometimes, as you know, even political or economic treaties sometimes take years to get the government instruments to approve them and implement them. And then abide by them is another issue. Just to come back to for a moment to Meta and your need for or your demand that the countries report things. Meta, it's become increasingly difficult for countries to hide things. It's not just the media reporting things. It's Twitter and it's Facebook. And other ways of looking at data sets to see whether there's something unusual going on. So is it possible to hide something? Maybe in some places in the world, but it's increasingly more and more difficult. And I'm not sure that we need a law to demand that. We have some persuasive things like the international health regulations that are persuasive to encourage countries to report, but they can't hide. You can't hide so much anymore.
Let me ask a new question, because just a little over an hour ago in my email, I got a very interesting letter from somebody I don't know named Gabriel Armas Cardona. And it's a call for experts on human rights and public health emergencies. And it says, do you know anyone else who has worked on the challenge of realizing human rights in the face of a public health emergency such as COVID-19? The GHLC, or whatever that is, and the ICJ, I know what that is, are developing the Human Rights Guiding Principles for Public Health Emergency Preparedness and Response. All that's italicized, so it's apparently one title. And are seeking expert input on the current draft principles to ensure that the principles are applicable to real life situations. If you want to nominate yourself or somebody else, let me know. Now, I don't know what this is, but I figure it came just at the right moment, so I can ask you. I presume maybe they're talking about something like what went on in, was it Shanghai recently, where they locked everybody in for weeks at a time, people who couldn't even go out and get food or anything. Was it Shanghai? Anyway, yeah. This may have been what they have in mind when they're talking about human rights. What do you think? What's this story all about, and does it mean anything to you?
If I may just make a quick comment. The SARS coronavirus pandemic brought about a clash between the individual's rights to do whatever they want to do and the rights of the community to be protected. And this is a clash. There are people who felt that, and we experienced it here in Canada, there are people who felt that there should be no restrictions on their rights, their perceived rights to walk around and cough and do whatever. On the other hand, there were advocates of the right of the community to be protected and demand that people behave in a certain way. We didn't exactly resolve that. We sort of muddled through it with mandates on public transportation to wear a mask and things of that nature. But I think the ethicists and the human rights people need to come to grips with this potential clash, because it's going to happen over and over again with an infectious disease. I'd be interested in your comments, David.
Yeah, no, I agree with you. And vaccine mandates were another issue.
Yeah.
That people felt they shouldn't have to take the vaccine. So these things have to be balanced equally between protecting the public and protecting the individual. And, if the COVID vaccine had been a vaccine that prevented infection, then there would be a real necessity for everybody to get vaccinated to get rid of this virus out of a community. But because it didn't protect against infection, it only protects against serious illness and death, it's not the same justification. And so people were using this as an argument why they didn't need to get vaccinated, because it wasn't really a public health intervention, it was a personal protection intervention. And so, all these different discussions have to come to a head, as you say, Ron, and people have to do this head on and come out with some understanding of what's a human right and what's a right of the public, because they both interact and they're both important.
And I in my opinion, it's my opinion, personal opinion, that here in Canada, at least, the public health community did not do a really good job of messaging this for the public. I don't think there was ample discussion, debate of the pros and cons of the protection of the community versus the protection of the individual, and the issues that came up over vaccine, masks, social distancing, closure of gyms and restaurants, and so all of that was put in place. I don't think there was good public health messaging.
Do you think it's necessary to have an initiative such as this letter seems to suggest is underway, to have some debate or maybe even a treaty or something, some way of working out what the boundaries are between the rights of people to leave their homes and whatever they please, and public health concerns?
Well, the problem I see is it depends. It depends. Not all infectious diseases are the same. They're not the same in their infectiousness. They're not the same in their mortality, morbidity. I hesitate to think what would have happened if this coronavirus, SARS-2, had the mortality rate of the MERS virus from the Middle East. If we had a mortality rate of 35%, we would have had chaos and total closure of everything. Mm-hmm. So they're not all the same, but there are some basic fundamental principles that should be carefully elucidated and discussed and debated.
Mm-hmm. David, you want to have the last word? We're about time to finish.
Yeah, no, I think that in discussions like this, they can't be top down. They have to be bottom up. And so communities have to be discussing this. They have to then promote these ideas among their local government, within provincial governments, and finally national governments. And these discussions take a long time, but you can't impose a human right requirement from the top down. I think it has to come from the bottom up.
Okay, thank you. This has been fascinating and I think extremely valuable. I hope lots and lots of people watch it, because I think I learned some things, and I'm really very grateful to you. It sort of sets the agenda for a lot of other conversations, right? Okay. Thank you both.
David, thanks so much. Thanks so much, David.
Thanks, Ron. Thanks, Meta. Really nice to talk with you.
Bye.
Take care.
Bye-bye.
Project Save the World produces one of these shows 3 days a week, sometimes more. This is episode number 481. You watch them or listen to them as audio podcasts on our website, to savetheworld.ca. And sometimes we even post the transcripts there. And when you get there to that website, look around. We have conversations there about 6 global issues, plus potential reforms in governance, economics, and civil society. To find a particular talk show, enter its title or episode number in the search bar, or the name of one of the guest speakers. And after you've watched or listened, share your own thoughts about the show. This is a place for dialogue. Project Save the World also produces a quarterly online publication, Peace Magazine. You can buy a single copy or subscribe for $20 Canadian per year through PressReader. Just go to pressreader.com on your browser, and in the search bar, enter the word peace. You'll see the cover of the current issue and buttons to click to subscribe.